All right. Hello, this is Christopher South, the Easy EMT. And today we're going to be talking about understanding the A and the ABCs. And most of us are pretty familiar with the ABCs. We've probably learned it, and whether in EMT or paramedic school. But how often do we think about airway management in all of our patients? We typically only think about it in codes, trauma, and things like that. But airway management is important in all of our patients. But before we get started with that, let's talk a little bit about something I think is very important within our industry. Now, Rear Admiral Grace Murray Hopper has this fantastic quote, and I like to give it. It says, "The most damaging phrase in the language is we've always done it this way." Everything changes. What we're talking about today, when we're talking about airway and ventilatory support, is we're talking about change. We're talking about change. It happens with every breath that we take. Is there's changes that are not only with the COO2 exchange where we have that change, but we also have changes in our pH that happens when we breathe. But change is inevitable. It's something that is going to happen. In our industry, we have to be able to embrace changes because we're not doing things based off of tradition. We're doing things based off of evidence-based guidelines and evidence-based medicine. And so it's important for us to embrace change. So Socrates said something that was really important. He said, "The secret of change is to focus all of your energy, not on fighting the old, but on building the new." And so this is what we're doing today is when we're going through and looking at our training today on ventilations and airway is looking at change. This is what is going on is we're looking at biological, physiological changes and everything, but within our industry, within EMS, we need to also get away from the old and start embracing the new. And I know change is hard and everything, but change is good. And that's what Henry Rollins said. He says, change is hard, but change is good. So our objectives today is we're going to differentiate between adequate and inadequate breathing. We're going to look at the differences between respiratory distress and respiratory failure. We're going to differentiate between alveolar ventilation and minute ventilation. We're going to explain when to oxygenate and when to ventilate. We're going to explain the effect of ventilation on venous return and cardiac output, spontaneously breathing patient. We're going to talk about an artificially ventilated patient. We're going to identify the use of automated transport ventilators when managing patients. We're going to be talking about the 3-button vents, the ATVs. We're not going to be talking about big ventilators. That's for a different course. We're going to discuss the American Heart Association's position on routine suctioning of the newborn. We're going to demonstrate effective bag valve mask ventilation at a proper rate and depth. And we're going to assess the advantages and those disadvantages of various advanced airway adjuncts. All righty, guys. So let's get going. So let's take a look at our anatomy of the respiratory system. So let's start with the airway. So we look at the upper airway. All right. So air either enters through the oral or the nasal airway. Okay. So if we take a look, we're going to start at the top there. And so air comes either through the nares if we're looking at the nasal airway, and that air is warmed. All right. So air has to be warm before it travels down to the body. If it didn't happen on a good I live in Northwest Iowa, but I work in Minnesota. In Minnesota in the winter, if you went outside and it's 20 degrees out, if we didn't warm that air, it would actually freeze in our lungs. So it's really important. So we're looking at the hard palate, which is the roof of your mouth. We have the oral cavity, and we see one of those huge airway obstructions right there is the tongue. So the nasal pharynx and the oral pharynx, as they go down, they go past the soft palate. We have the uvula that hangs out. The oral pharynx narrows down, and this is where we have the split off. All right. We have the epiglottis, which is a little flap that goes over the larynx. All right. The larynx is where the vocal cords and everything are. We have the thyroid cartilage and the cricoid cartilage. All right. And so this is where we're going to be looking at is with ventilation is getting air down to that passageway. On the other side of the epiglottis and everything, we have the esophagus. All right, which is where all the food goes. But what we're looking at is ventilating air into the trachea, down into the lungs. So let's take a look at that anatomy. So the larynx and the trachea, all right, so we see the trachea right here. Let me get our little pen out. All right, and then it splits off at the right primary bronchi, all right, and the left primary bronchi. All right, and so it splits even further down into the bronchioles, the alveolar sac, and eventually to the alveoli. All right, so this is our lower respiratory tract. We'll be talking a little bit more about that in just a minute. But I want to talk a little bit about what ventilation is. And so we think about ventilation, we get really excited about, well, we're bagging, we're ventilating, we're getting air in. All ventilation is, if you think about it, is air being moved from one environment to the other. That's it. And our air that we breathe just every day, walking around here in Minnesota, where I work at, the elevation here is about 1,200 feet. We're getting 20.9% oxygen, but most of what we're breathing in and what's found in the atmosphere is nitrogen. There's 78% nitrogen. There's less than 0.3% of carbon dioxide. There's other gases, which are noble gas airs, and then argon. And so this is really what we're seeing within our atmosphere. So there's a question. If you were at the top of Mount Everest, which is a little over 29,000 feet, all right, if you're up there at the very top, struggling to breathe, how much air, how much oxygen is in the atmosphere? Well, it's still 20.9% oxygen. The problem is there's not enough pressure for all of those oxygen molecules, because they're all spread out, is because they can kind of free float up there. Is if that pressure was down to sea level, you would be able to breathe at 29,000 feet. The problem is there's just not enough pressure. We'll be talking about pressure here in just a second. So let's look at our breathing process, how we actually breathe. All right. So breathing starts at the nose and mouth. You inhale air into your nose or mouth, and it travels down the back of your throat and into your windpipe or your trachea. Your trachea then divides into air passage called bronchial tubes. For your lungs to perform at their best, these airways need to be open during inhalation and exhalation and free from inflammation or swelling in excess or abnormal amounts of mucus. And so that's normal breathing. We're going to talk about some of those problems that I just discussed. As the bronchial tubes pass through the lungs, they divide into smaller air passages called bronchioles. So these are kind of smaller tubes. Those bronchioles end in tiny balloon-like air sacs called the alveoli. Your body has over 300 million alveoli. Man, that's amazing. The alveoli are surrounded by a mesh of tiny blood vessels called capillaries. Here, oxygen and inhaled air passes through the alveoli walls into the blood. After absorbing oxygen, the blood leaves the lungs and is carried to your heart. Your heart then pumps it through your body to provide oxygen to the cells of your tissues and organs. As the cells use the oxygen, carbon dioxide is produced and absorbed into the blood. Your blood then carries the carbon dioxide back to your lungs, where it is removed when you exhale. And this happens with every breath. So let's take a look at the diaphragm's role in breathing. All right, that's the kind of muscle that's right there at the top of your abdomen. Inhalation and exhalation are the process by which the body brings in oxygen and expels carbon dioxide. The breathing process is aided by a large dome-shaped muscle under the lungs, and it's called the diaphragm. When you breathe in, the diaphragm contracts downward, so it's actually pulling air in. It creates a vacuum that causes a rush of fresh air into the lungs. Well, the opposite happens when you breathe out. The diaphragm relaxes upwards, pushing the lungs and allowing them to deflate, which pushes out all the carbon dioxide. And this is a normal role in breathing. So we're talking about that CO2 exchange. The hemoglobin are kind of like little, I guess, box cars on a train. And so they're picking things up and dropping things off. And so what they're doing is they're picking up oxygen and offloading carbon dioxide. And this is what we're looking at. So now let's take a look at tidal volume, minute ventilation, and alveolar ventilation, or alveolar ventilation. So tidal volume is the amount of air inhaled and exhaled during each normal breath. So it's in and out, and it's at volume. All right. So the average person coasts on the exhale side of their breathing cycle at 10 to 15% of their tidal volume. So this is how to calculate tidal volume. Tidal volume is the amount of air that passes in and out of the lungs during normal breathing. It can be measured physiologically with expensive pulmonary equipment at a laboratory, which we don't have on the ambulance. All right. Calculate the ideal body weight using the Divine formula. So for males, the formula is 50 plus 2.3 times the product of height in inches minus 60. And that is a tough one to kind of think about if you don't have that information right in front of you. For females, it's 45.5 plus 2.3 times the product of height in inches minus 60. Various other formulas are available. However, the Divine formula is one consistently used in pulmonary research application. And this is important, especially when we're putting patients on ventilators and things. So calculate the tidal volume by multiplying 12 milliliters by the ideal body weight in kilograms. Keep in mind that this is not a physiologic determination of tidal volume. It's only an estimation because everybody is different. This formula is for someone who is resting comfortably and in excellent health. Not everybody is in excellent health, especially the patients that we're going to be dealing with. For patients with asthma, emphysema, you're going to multiply by 10 milliliters by the ideal body weight. Critically ill patients in the intensive care unit have even a lower tidal volume of 8 milliliters per kilogram. So let's say we have a patient who is in exacerbation with asthma. All right. So we may not be thinking about 10, but I would probably go with 8 for that. And let's say they're 100 kilograms. All right. So we're going to take 8 and we're going to multiply that times 100. All right. And so we're going to get what? 800. Add 300%, add 30% to tidal volume for pregnant or lactating women is because we've got to have a little bit of extra volume there for the fetus. During and after pregnancy, women need more air in their lungs due to higher oxygen requirements. The oxygen is passed on to the infant and used to increase milk production. So there's a little bit more going on. So we need a little more oxygen to keep that factory going. Reduce the tidal volume by half for children. Children have lower oxygen requirements and thus do not require as much air to pass in and out of the lungs. So minute ventilation. It is the volume of air a person moves in and out of the respiratory system in 1 minute. So calculating minute ventilation, this is important, especially for placing patients on ventilators. The volume of air a person moves in and out of the respiratory system in 1 minute. So the minute ventilation is the tidal volume times the respiratory rate. So let's say that we have a tidal volume of, we're going to say 600 and a respiratory rate of 10. So what is 600 times 10? Tidal volume is the volume of air a person moves in and out of the respiratory system in each breath, and the respiratory rate is the frequency, is the number of times a person breathes per minute. So example, like we just talked about, is let's say we have 500 milliliters. This is a tidal volume times 12 breaths per minute. So minute ventilation is 6,000 milliliters per minute. So the alveolar ventilation, VA, for short, is the amount of air that moves in and out of the alveoli per minute. So the alveolar ventilation is a major factor in determining the cone of O2 and CO2 in the alveoli. All right. So the alveolar tension, or PaCO2, is regulated at the value of 40 millimeters of mercury, determined by the rate of production in alveolar ventilation. So to calculate that, we take the tidal volume minus the dead air space. So you're going, what in the heck is dead air space? So ventilation is just volume, as we are just putting volume down into the lungs, down into the airway. But remember, down at the bottom is where the alveolar the villi are happening at. That's where we're getting that CO2 exchange. But all that other space that's in there that's having to keep that volume, that pressure for that to happen is air, but it's not air that's getting oxygenated. And so this is called dead space. So we minus the dead air space times the respiratory rate in 1 minute. All right. So if you're looking for that formula, so we look at alveolar ventilation is the tidal volume minus the dead space times the ventilator. The example is 500 milliliters of air minus 150 milliliters of dead space times 12 breaths per minute gives us 4,200 milliliters per minute of alveolar ventilation. The difference between minute ventilation and alveolar ventilation is important because alveolar ventilation is the volume of air actually reaching the alveoli that participates in gas exchange. That's actually what we're looking for. It's what oxygenates the blood. So by increasing the rate of ventilation in a patient with shallow breathing, for example, it's a person who has an inadequate tidal volume may maintain the minute ventilation near normal. However, alveolar ventilation, gas exchange will be inadequate. So we have to look at things, all right? Ventilation and oxygenation are two completely different processes, but they work hand in hand, all right? So we have to make sure that we're getting an adequate enough volume so we can have good gas exchange, but we don't want to give too much volume, and we're going to talk about that in just a second. So inadequate ventilation causes. So here are some of the causes why we have inadequate ventilation. We can have inadequate breathing, which is caused by inadequate tidal volume, inadequate rate, or a combination of both. Any of these things is going to cause problems where we're not getting good oxygenation or offloading of carbon dioxide in the alveoli. We want to have that good CO2 exchange in the alveoli. So let's think about it. Inadequate breathing requires immediate management with positive pressure ventilation. And so it doesn't always have to be a back valve mask. And we're going to talk about the importance of CPAP here in just a little bit. But we need to recognize inadequate breathing and what we need to do for it. The effects of ventilation on venous return and cardiac output. So this is really important. And this is what I like to call the bad bagging section of our training today. In the normal patient, the negative pressure that causes inhalation facilitates venous return necessary for adequate cardiac output and perfusion. Cardiac output is the amount of blood ejected from the left ventricle in 1 minute. So cardiac output, if you guys probably remember this from school, is the stroke volume times the heart rate. Stroke volume is the amount of blood ejected from the left ventricle with each contraction. So with each contraction, when that left ventricle pumps, it's the amount of volume that is ejected out. So the heart rate is the number of times a heart contracts in 1 minute, also known as the pulse rate. Negative pressures during inhalation allows venous blood return to the right side of the heart, which is necessary for adequate cardiac output. So we're going to learn a little bit about that here in just a second. So hang tight to that thought. So some ventilation complications. Artificial ventilation pushes air into the chest. Positive pressure ventilation. And what can happen is increasing intrathoracic pressure. So we think about our thoracic cavity, which is on the outside of the thoracic cavity is we have our ribs, okay? And our ribs inside of it is we have the lungs, and next to the lungs is we have the heart. And all of that is encased inside of a space. So if you start adding too much pressure inside of that chest cavity, those lungs have got to go somewhere. They can't inflate outside of the chest cavity due to the ribs. So what it's going to do actually is it's actually going to squeeze against the heart. And so the heart's not going to be able to pump effectively. And so if we're not able to have the heart to pump effectively, not only are we going to have complications with ventilation, with adding way too much pressure, we're going to talk about some of those things here in a second, but the heart is not going to pump like it needs to. And so if we got a patient in cardiac arrest, for example, and we've got maybe we got smart and got our Lucas on, or maybe we're doing compressions, but If we are overventilating and that heart is having to work against lungs that are pressing up against the heart itself, then we're going to have poor cardiac output. And so, what I like to tell all of my students and everything, which is you guys listening at home, is bad bagging leads to poor outcomes. So, again, bad bagging leads to poor outcomes. So, how can we get good outcomes? We get better at bagging. So we talked about increase in intrathoracic pressure impedes venous blood return to the right side of the heart. So excessive ventilation. Now this, I came from EMS in the 90s. That's where I started my career at and everything. And so when we did a lab where I went to school, they had us squeeze half the bag, and that was how we knew. We didn't learn that good ventilation and everything. It was just how we did it. So excessive ventilation rates during positive pressure ventilation decreases cardiac output, and which causes decreased vital organ perfusion. And we don't want to do that. We want to make sure that we're getting good oxygenated blood flow down to the organs and keeping them perfused, keeping good blood flow and everything happening. And so good bagging can be of a benefit, but overventilation can definitely cause a whole lot of issues. So what we need to do, and when we're thinking about bagging, is we just want to bag enough to see chest rise. Once we have chest rise, we know that we've got adequate ventilation and we can let off. We don't want to overventilate. So better bagging, again, better bagging leads to better outcomes. All right. So if you will take a look at this picture just for fun and everything, you will see that this C collar is upside down. Woo, have a lot of fun. All right. For adults, artificial ventilatory rates greater than 12 times per minute or one ventilation every 5 to 6 seconds decreases cardiac output and perfusion. Don't overventilate. Okay. Do not exceed a ventilatory rate of 10 to 12 times per minute. And that's at one every 5 to 6 seconds. I tend to be a kind of a 6-second guy because I want good ventilatory. High artificial ventilatory, if you're greater than 12 per minute, results in poor patient outcomes. It absolutely does. So here's the thing. We need to be thinking about as soon as we have a patient who is calling for shortness of breath, dyspnea, all right, we need to be thinking about, is that patient going to stop breathing on me? Every single time. Now, one of the things that I teach my EMT students when they're going through school is I tell them, you should assume that every single person that you meet in the back of an ambulance is dying until proven otherwise. And you're going, well, that's about the dumbest thing I've ever heard. Well, let's say that again. Assume that every patient in the back of that ambulance is dying until proven otherwise. Because if you do, you'll do good assessments. You will manage that care. You'll manage that airway, breathing, and circulation to make sure that that doesn't happen. And so we're going to be looking at respiratory distress versus failure. So here's a pop quiz question for you. And I like to ask this question and really surprise the heck out of students is I ask them this. Can a person say that they can't breathe or that they're not breathing? And can they not be breathing and still make a sound, yell, scream, or even talk? And that answer is yes. Because our vocal cords work as air is coming out, not when air is coming in. And so a patient can absolutely yell out and say, I can't breathe, and absolutely be right. When a patient tells you they can't breathe, you should take it seriously until proven otherwise. So we're going to take a look at respiratory distress versus failure. So in respiratory distress, we have an open airway without support. The respiratory rate that can be a little bit fast, which is known as tachypnea. We can have increased effort, is where they're really kind of taking some deeper breaths. Now, in respiratory distress, this is a little bit different. The lung sounds can be clear and they can still be short of breath just because they don't have any signs of, like we're starting to hear like abnormal sounds. The heart rate is typically going to be increased because we have an increased effort and increased respiratory rate. So we're going to have tachycardia. So those patients can be agitated. It's because they're struggling to breathe and everything, and because they need that help. Sometimes they could be like, I can't breathe, I can't catch my breath. And you're trying to work with them and ask them a lot of questions, but it may be hard for them to answer those questions because they're struggling to breathe. They can have pale skin, is because, if we do have that, we can have where everything is getting shunted toward the lungs and the heart, is because they're having to work a little harder. The appearance of capillary beds, especially in adults, can be variable, is because it's a little better to use that with children than versus adults, is because adults have what I like to call adult problems. They can have um, poor output. They can have issues like with vascular disease and things where you may not have good capillary return. So in respiratory failure, the airway can be possibly obstructed. And we're talking about the airway being obstructed. Doesn't mean that it's the tongue or anything like that. It can be with respiratory failure, but we can also have things like secretions that could cause obstruction. And so suction is absolutely your friend. But the airway can also be possibly obstructed by simple things. If we have like an obese patient, for example, their weight down their lungs and on their neck and everything can cause that. And so we need to think about positioning, lifting those patients up and getting that airway open. But sometimes in respiratory failure, we actually start seeing where that airway starts to become obstructed, whether it's the upper airway or the lower airway. So let's think about the airway itself. We tend to think only about the airway from the nose, mouth down to the trachea, but the lower airway down to the bronchus and the bronchioles and everything, it can be obstructed too. And so we can have obstructions where we have um, constricted airways due to things like asthma, chronic bronchitis, emphysema. We can have fluid that can be in the lungs from pulmonary edema. We can actually have a thrombus that's in the lungs from a PE. And all those things can be an obstructed airway. So the respiratory rate is going to be more slower at respiratory failure, is because that person has been tachypnic. They've really been working to breathe and everything. And now that muscle is beginning to fail. They've really been using like those accessory muscles and it's just not working. Now that breathing is slowing down to the point that we're not going to have any effort. So here's the thing: respiratory distress leads to respiratory failure leads to respiratory arrest, and respiratory arrest leads to cardiac arrest, and cardiac arrest leads to death. So we're seeing a cascade here. The best thing is to get ahead of it during the respiratory distress side. Lung sounds and respiratory failure are going to be abnormal, and it can be anything from wheezes, bronchi, all of those things that we have. So as that person has been struggling for so long to breathe, bradycardia with respiratory stuff is typically a bad sign. So with responsiveness, we may start seeing like altered mental status, but it could get to where the person becomes unresponsive. And then if anytime we have respiratory stuff and a person becomes unresponsive, we need to act quickly. That person can start to become cyanotic, and we can see that even with people with like asthma or having an asthma attack. So once we start seeing bluishness in the skin and everything, that lets me know that everything has gotten shunted into our cardiovascular system, our pulmonary system. We're getting our cardiopulmonary system is not functioning effectively. We need to act fast. And so let's think about bag valve mask ventilation. The first thing is you have to select the correct mask size, either adult, infant, or child. They are not one size fits all. So we're going to make sure that we are positioning right. So if you take a look at the picture, they're doing it right. The thumbs over the top half of the mask and the index and the middle fingers over the bottom. They're pressing down and getting a good seal. The better the seal that you make, the easier it is going to be to ventilate. And so we can actually see the lungs rising and falling in the chest. Place the apex of the mask over the bridge of the nose and lower the mask over the upper chin. If mask has large round cuff, position the center port over the mouth. So if there's no chest rise, all right, we give a ref, we don't see any chest rise, reposition that basic airway. If air is escaping from under the mask, reposition and try again. Check for obstructions. Do we have a tongue or anything that's in the way? Do we need to clear the airway with suction? Do we need to place an oral or a nasopharyngeal airway? If chest still does not rise and falls, use alternative method for artificial ventilation, such as a pocket mask or a manually triggered device. Now, those oscillators and things, be very, very careful with if we're giving jet ventilated, manually triggered device ventilation, is because we can cause damage. Consider the use of adjuncts such as oropharyngeal or the nasopharyngeal airway. The preferred method and the one that works best with bag valve mask ventilation is the two rescuer, just like we see in the picture. And the reason for that is we get a better seal and we get better control of that airway. The technique is more effective. All right. So the one person is holding the mask in place to the patient's head. Adjunctive airways, oral nasal, may be necessary with that bag valve mask, is to keep that tongue out of the airway, especially when those patients are unresponsive. For trauma, maintain inline immobilization. Anytime we're doing that, so we don't want to be cranking their neck back or anything. So here are those complications that I've been talking about from using a bag valve mask. It does increase pressure in the chest. It decreases cardiac output. If we squeeze too much, we could cause a pneumothorax. We get gastric inflation. And here's what's really bad. Gastric inflation, if there's only so much air that's in the belly, the content of our GI system is going to come back up into our airway. And then we're going to have airway complications again. So if you're bagging too much, be prepared to suction, especially if you're noticing that you're getting gastric distension. CPAP. So a lot of us are pretty familiar with CPAP. It's that device that's on the truck. It's a little box beside a patient's bed like me, who snore constantly and gag and stuff in their sleep. CPAP stands for continuous positive airway pressure. So let's take a look at how CPAP works to improve breathing. What it does is it maintains a constant level of airway pressure, so it's volume. It keeps the alveoli open, moves fluid into the vasculature. So we have a patient with congestive heart failure. It pushes that fluid through. It improves gas exchange. So one of the things is it buys time for meds to work. And in some CPAP systems, which I highly advise people to use, is a CPAP system where you can administer medications during CPAP therapy. So you could give like inline medications such as albuterol or Aduhelm. So here are indications for using CPAP. Patients needing ventilatory support who are in moderate to severe respiratory distress, or early respiratory failure. Patients must be awake, able to obey commands, and have intact airway reflexes. So here are contraindications. The patient is in respiratory arrest, so we need to be bagging with a bag valve mask. The patient is suspected of having a pneumothorax. So the way we know that is we have absent breath sounds. Patient has a tracheostomy, because if we're blowing CPAP in, it's just going to come right out the trach. Or if the patient's vomiting, definitely a contraindication. So here are some of our precautions. And if you notice on this one, this is a fantastic device, and it's pretty similar to the one that I have at my service where I work, is that we can give an inline treatment. So some of our precautions: use care if the patient has impaired mental status and is unable to cooperate with the procedure. Now, this doesn't mean that the patient, when we're first putting it on, is they're unsure, maybe they're scared. So a lot of times a little gentle coaching and stuff helps a lot is because that patient's gonna be anxious, they're struggling to breathe, and here we are right there by their face, squeezing this mask down on them and putting this really scary headset on. So talk them through the procedure, try to ease them through it. So if a patient has failed at past attempts at non-invasive ventilation with CPAP therapy, paramedics need to be thinking about the possibility of intubation. Has active gastrointestinal bleeding or history of recent gastric surgery. Patient complains of nausea or vomiting. Has inadequate respiratory effort. Has excessive secretions because they're going to require suctioning, which you can't do with that. Has facial deformity that prevents the use of CPAP, and it should be used in caution with children under 12 years of age, and should start with lower pressures of about 2 centimeters of H2O. So some more precautions. An inline bronchial dilator nebulators may be placed in CPAP circuit if needed. Don't remove the CPAP device until the hospital therapy is ready to be placed on the patient. So we just don't, when we're turning our patient over at the hospital, just snatch it off of them. Most patients, which most doesn't mean all, will improve in 5 to 10 minutes. If there's no improvement during this time, consider increasing the pressure and preparing for drug facilitated airway management. So we're thinking about intubating this patient. Watch the patient for gastric distension because it often presents as vomiting in a conscious patient. So if we start seeing distension, seeing their abdomen getting big, what can happen with CPAP, we need to be prepared to snatch that mask off and allow that patient to vomit. Use nitroglycerin infusion rather than spray to prevent breaking the CPAP seal or dispersal of medication on rescuers. Remember that CPAP applications don't violate, do not resuscitate, or do not intubate orders. So if we have a patient who has a do not resuscitate, known as a DNR, maybe they have pulsed orders where they don't want to have, like intubation and stuff, CPAP can still provide ventilatory support, good care, allow that person easier time breathing and everything without violating that. Consider the ALS administration of Ativan for anxiety associated with CPAP use, bearing in mind that, well, Ativan may result in respiratory suppression is because Ativan is a benzo. So let's say we have a patient who is on CPAP, they suddenly come unresponsive, everything, and we're ready to ventilate with a bag valve mask. If we've got a good tight seal with our CPAP, we can just swap over and start bagging them with the CPAP mask, and it actually does work. So ATVs, and I'm not talking about the fun kind that we ride around on the farm. This stands for Automated Transport Ventilator, ATV. One of the things that I call these little things, the AutoVent 3000s, is a 3-button. Is because it typically has like the breaths per minute, your I time, and the tidal volume. So the benefits of using an automated transport ventilator is in intubated patients requiring artificial ventilation for a period of time may benefit from an ATV instead of using a BVM. The advantages are is it can be used for breathing and non-breathing patients, patients in respiratory failure, and frees the rescuer for other tasks because I'm not having to use my hands. So the disadvantages, it does need an oxygen source and sometimes electric power depending on the device. The inability to detect increasing airway resistance, and some ATVs should not be used in children younger than 5 years of age. So like with any medical device, there's always good things and bad things about them. So airway adjuncts. So this class that we're doing online is just talking about some of the background and some of the history that we need to look at as far as doing our assessment. But the airway adjuncts, if you would like, just hit me up and you are free to come in and I'll be more than happy to go over some airway adjuncts with you and practice. So the oropharyngeal airway is an OPA. All right. So the indications is respiratory distress, failure, and those patients have to be unconscious, unresponsive patient is because they don't have to have, they cannot have a gag reflex. So the contraindications is a gag reflex, the presence of oral trauma such as broken teeth, recent oral surgery, and other things. So the way that we are going to measure it is we're going to measure from the ear to the mouth to find the right size. So a nasopharyngeal airway, also known as the NPA, is indicated in respiratory distress or failure. Our contraindications are going to be the presence of head, facial trauma, or the presence of a skull fracture. So to measure our nasopharyngeal airway is we're going to go from the ear and measure over to the nose. Supraglottic airways, some of the examples is we have the laryngeal mask or LMA, all right, the esophageal tracheal tube, such as the combi tube, which can be found here. And we have the laryngeal tube, which is called the King LT. But my favorite out of all of these is the iGel, and this is the one that we use here at our service is the iGel. So the advantages of the supraglottic airway is it does not require visualization of the glottis. And so it's blind insertion. So basically you just place it down in the airway. Initial training and maintenance of skills are a lot easier. So it's not like intubation where you require a lot of training and practice. Chest compressions do not need to be interrupted to insert. Minimal equipment required for insertion. So these are good things. And that's why I like the iGel, man. It's super easy to put them down. So that's an iGel. And here are some of the disadvantages. Like I said, with any piece of equipment, there are ways, good things and bad things. They are contraindicated in patients with a gag reflex. Some devices contraindicated in patients at risk for regurgitation, which can lead to aspiration, especially in the LMA. Unrecognized improper placement can occur. Additional contraindications common per local protocol. Now, one of the cool things about the iGel and some of these other devices and everything is that you can place capnography on top so we can know if we're getting ROS back immediately, but also to see how our ventilations are doing. Now, the gold standard with maintaining an airway should be the ET. The advantages that keeps the airway patent. It may protect the airway from aspiration and allow suctioning of deep airway secretions. And there are a few drugs that we can use to go down the endotracheal tube. And one of that, a good way to remember that is Lane, lidocaine, atropine, Narcan, and epinephrine can all be given via endotracheal. Disadvantages, and there is a lot. Difficult initial training is because it takes a while to learn how to intubate. Insufficient skill maintenance without frequent practice. This is so important. And I just nail this on paramedics all the time. You need to practice intubation. If you want to get good at intubating in the field and everything, you've got to practice and you got to practice often. If you're at your service and everything, if they have an airway mannequin, get it out, get those tools out, practice, is because with intubation, we can frequently cause trauma to the oral pharynx. Hypoxemia can be possible with prolonged intubation attempts. Adverse outcomes common when the provider fails to recognize tube misplacement. High incidence of complications when performed by inexperienced providers with inadequate monitoring of tube placement. So this is important to have what? Lots and lots of practice. So positioning of the pediatric patient for artificial ventilation. So we want to make sure that patient is in the sniffing position. So sometimes we have to put a little bit of padding behind the shoulders, may help that patient, the pediatric patient, to get into that position. And the reason is because pediatric patients tend to have larger heads in comparison to the rest of their bodies. So here we go, newborn care, suctioning the airway. So the American Heart Association states that suctioning the airway in the newborn may cause bradycardia. Suctioning immediately following birth, including the use of a bulb syringe, should only be done in newborns who have an obvious obstruction to spontaneous breathing or who require positive pressure ventilation. This is something new. The presence of meconium does not necessarily require suctioning. Hey, so this is Christopher. I hope that you enjoyed learning a little bit about ventilation and why it's important, what's going on down inside of our lungs when we're ventilating, and some of those complications, looking at some of those adjuncts and everything. But I want to stress that it's super, super important for anybody, whether you're at the basic level or at the advanced level, to practice using your tools and managing the airway, whether it's learning how to properly use suction, using your adjuncts effectively, intubation, going over all of that. So practice, practice, practice makes perfect. And once again, bad bagging leads to poor outcomes. So get better. Better bagging, better outcomes for our patients. So thank you again for watching this video. And if you have any questions or anything, I've always got my information in the comments section. And if you haven't yet, hit that like and subscribe button. Please do so. It does help me out. So once again, this is Christopher South, the Easy EMT. Goodbye.